but I can resort to bribes. So when you do the evaluations, just remember, anyone who gives me a bad evaluation, next time you get nothing. Ronnie, you want to hand these out?
Prize.
Brian.
Oh my goodness, wow.
Okay, we're going to talk about coma and altered mental status. So, this is my dog Casper. So one day, true story, I came home and I found him like this. First I thought maybe he was hitting booze, maybe he had overstudied like some of you would right before the board test. But it turned out he was in diabetic coma. The blood sugar was over 500. Okay, so we're going to start with a case. We have a 72-year-old patient, diabetes, hypertension, CHF, coronary artery disease, UTIs, presents to UHB with a 3-day history of increasing altered mental status. Also coughing, shortness of breath. Her medications are glyburide, aspirin, Cipro, metformin, furosemide, digoxin, low pressor, and a bunch of over-the-counter stuff. This is her vital sign, okay? And noted her pulse is irregular. Orally, she has this borderline temp. She's confused and disoriented, but she moves all her extremities, no evidence of any focal lesion. So your job is, how did I, or how would you, further evaluate her? What were the most likely diagnoses? And what was the management then? We'll get back to her, okay? So what are our goals and objectives? We want to learn how to evaluate patients with altered mental status, and we want to learn how to manage them. So, what is our overview of what I'm going to cover? Some important clinical considerations, approach and evaluation of altered mental status patients, differential diagnosis, and management. Okay, so why am I going to waste 45 minutes of your precious time talking about this? Well, altered mental status is very common. If you look at some of the studies, 1 out of 10 are elderly patients who present to the emergency department have delirium. 1 out of 4 who are admitted, sometimes during their course, have delirium. So very common and very dangerous. They may suddenly rapidly deteriorate and fall off the cliff and die if you don't jump on them. Also, a lot of the etiologies that will cause them to deteriorate may present as altered mental status. Anybody recognize that guy? No? Dr. Fahmy? Okay. So what are one important consideration? The ABCs always take precedence, right? You don't want them to die when you're with Josh talking about, some important teaching points, right? Airway, breathing, circulation, always. All right. Also, altered mental status is sometimes the first sign of a bad process going on. A stroke, hypoglycemia, sepsis, right? And it's a common presentation of many diseases, especially in the elderly, who may not just have one underlying problem, but several, like this case that I presented that we'll talk about later. Okay, so one of the important things you have to ask yourself, is this a toxic metabolic problem that I'm going to treat medically? I got a great EM guy like Willis back there that'll help me do that? Or do I need a neurosurgeon to treat a structural problem like a epidural or a subdural. Right? So the management of toxic metabolic stuff is going to be medical, emergency medicine, right? The management of focal neuro disease may be neurosurgical. And if it's going to be that, you got to pick it up early, and you got to get the neurosurgeon out of bed or out of the coffee shop and help your patient. And you're always the advocate for your patient. Okay? So the determination of a surgical correctable lesion is going to be, you suspect it clinically first. Maybe there's a focal problem. Maybe they're herniating in front of you and blowing their pupils, right? And then you're going to prove it by getting a CAT scan, getting imaging. Okay, so what's this dot in Yiddish? What is that? You speak Yiddish, so tell me what that is. What is that? Anybody? Okay, that is an epidural, and that person is herniating, right? And if you don't get that treated stat within an hour or two, they turn into a vegetable and die. Okay, so some definitions. So consciousness is how you relate to your environment. And as your consciousness gets altered, you go down the path. And eventually you get into coma. So for example, I'm hiding under the covers when I was practicing my lecture in coma on my wife and daughter. And they refused to come out till I finished practicing my lecture. Okay. So coma is a state of unresponsiveness from which the patient can be aroused by normal stimuli, right? Verbal, painful, especially painful, but nice painful, not twisting, stuff around. Enough said. Okay. So when you have someone who has altered mental status, right, there's two things you want to look at. One is their level of consciousness. Are they going down? Are they going to be in coma on you? Are they going crazy because they took cocaine or methamphetamine? But the other thing, even if they're awake, you don't want to miss, is the content of consciousness. Are they oriented? Are they making sense? Can they follow your commands? And there's a nice study in geriatric patients who had delirium that showed actually the majority of these patients were tricky to diagnose even though they had delirium because they had something called quiet delirium. And if you really spoke to them, they were confused and their attention span wasn't great. And they had a fluctuating consciousness, but they weren't yelling and screaming and trying to kick Gernsheimer, right? They were there just quiet, slowly dying. By the way, anybody ever see this movie? Coma, great movie. After the training exam in February, I give you permission to watch this movie. Oh, well. All right. Now, another thing you always want to ask yourself, when you have someone who's coming in and acting weird, is this organic or is this functional psychosis? There are a couple things can help you there. One is that someone is delirious, they're going to be confused, and they're going to have inattention, they're going to have altered mental status. Someone with functional psychosis, if you can get them to talk to you, even though they're weird, they're going to probably be oriented and they're going to have a decent level of consciousness. Also hallucinations. So what kind of hallucinations are the most common in delirium?
Visual.
So visual. You can also get tactile, right? Fornication, like bugs on your skin, with cocaine, not fornication. None of you are allowed to do that. Okay? Not till after the exam. Right. In psychosis, tends to be more auditory. And when they do have delusions, in psychosis, schizophrenia type, they tend to be, you know, oh, the devil is coming, and he's going to take Gernsheimer away where he deserves to be down below. And as versus some more disorganized stuff, like delirium, in delirium, where, oh, they're grabbing at bugs, right? They're grabbing at a string when someone is in DTs. You know that sign, right, Rich? You've seen it. Okay. So what about dementia versus delirium? So dementia is much more chronic, right? Delirium is very acute. It can be days, it can be just hours, right? In addition, in delirium, they're changing their mental status, their level. Whereas usually in dementia, their level of consciousness is the same, even though their content of consciousness is not good, right? And the one thing you got to worry about with dementia is they're at risk to get delirious. A lot of them are older, they have many diseases, they don't cope well with their environment, they're on many medications, and they're at risk to get delirium. When I was a little boy living on Hopkinson Avenue, now they call it Thomas Boylan. I always thought they'd call it Gernsheimer Boulevard, but they instead decided to name it after a politician. But my great aunt Rosie lived with us. She had dementia, but she got around. She forgot how to speak English. She only spoke Yiddish. She always thought I was her father, but she got around. One day, she became very disoriented, started running into the street, going back to her little shtetl, a little village in Europe. And then she wouldn't eat. And then the next day, she wouldn't get out of bed. So my mother brought her to Kings County. And they admitted her. They admitted her to the psych ward. Right? She died a few days later. Knowing what I know now, she was probably septic or having heat stroke, dehydration, right? But it was missed, right? Oh, my mother said, oh, they just think she's crazy. You know, she's just demented. Okay. So what is delirium, right? So if you look at the psych textbook, this is the definition, right? Acute confusional state with alternating mental status and inattention. Classical for delirium. Right? So here it is again. And it's caused by an acute medical condition. The patient is ill. Often they may have abnormal vital signs. And there are different kind of systems where you can look to see their delirium. And I'll let you look them up. The one I like best is called BCAM, Brief Confusional Assessment Method. Okay? I love these little acronyms or these little abbreviations. Okay. So we talked about the ABCs. What about the D? Disability, right? So you always want to do a quick neuro exam. So a quick neuro exam, number one, level of consciousness. Two, look at the pupils. Make sure they're not fixed and dilated. Make sure they're not blowing one on one side, which I'd worry about an epidural or a subdural or some kind of bleed or massive stroke. And look at the motor, that they're moving, everything. And especially you want to look for focality. You find that there's some focal difference on one side than another. Normally that means there's probably a mass type lesion going on. A bleed, tumor, something bad that you need to get a stat CAT scan for, okay? So how about the mental status? So you can be like Gernsheimer, a very simple guy, and just say, are they alert? No. Do they respond to verbal? No. Do they respond to painful stimuli? No. Oh, then they're in coma, they're unconscious, they're not responding to anybody. I better really jump on them and do the ABCs. Probably have to intubate and ventilate, right? But if you're fancy and smart, like a guy like Rich Sinner, right? Then you do something like the Glasgow Coma Scale, right? And these are the categories. You can go up to 6 for normal for the first, and 5 and 4, and maximum is 15. Anything less than that's abnormal. If you are a vegetable, you're 3. My wife thinks I'm somewhere around there. And if you're in coma, you're below 9, you need the ABCs done for you. And maybe something special, as we'll talk about, done for you to wake you up. Okay? All right, so some quick pathophys. You have to help me, Rich, because you're smarter than me when it comes to things like that. So, to have decreased level of consciousness, you have to have one of two things. You either have to have bilateral cortical disease. A simple little stroke in the cortex is not going to make you unconscious unless you have something else going on, like on top of it a metabolic problem, or it's so big that it's causing edema and herniation, right? However, lesions in the reticular activating system, lesions down in the brainstem, a stroke there will put you out, right? So cortical disease, when you have decreased level of consciousness, because you have to have a diffuse process, it's usually a toxic metabolic. And these are the most common there, right? Toxins like carbon monoxide, hypoxia, hypoglycemia, and sepsis, right? On the other hand, a stroke or something in the brainstem, or pressure coming down and crushing the brainstem, right? Or from the side, like a cerebellar bleed, crushing the brainstem. Those things will give you focality. You'll find neuro stuff there. And you'll know, hey, I better get a stat CAT scan. Hopefully it's something the neurosurgeon can help Gernsheimer with. Okay? Okay, so what's our general approach? Okay. Stabilize, ABCs, and then evaluate them. Okay? Don't let them die while you're teaching at the bedside. No offense. Said that twice already. Okay. Put in an IV and draw blood. Don't. Also called a coma cocktail. What do I mean by don't? Don't forget to think about it. D is dextrose. Check a finger stick. In the old days, they would call syphilis the great imitator. Nowadays, for me, the great imitator of any kind of change in mental status or neuro status is hypoglycemia. You don't want to miss that. And if you get a low sugar or even a borderline normal, you get D50, right? 50 cc's of 50% dextrose to adults, 25% to kids, and 10 to 15% in newborns, okay? Very important. I've seen hypoglycemia present as all kinds of things, including one woman at Lincoln that tried to bite me. She was hypoglycemic. And one of the few papers that I ever wrote, the only paper I ever was involved in writing in the annals of emergency medicine, was a paper on hypoglycemic hemiplegia. Person presented with a stroke, lab called the ER, oh, the sugar you sent us is 25, right? The resident hadn't done a finger stick. We gave D50, luckily it wasn't too late, the stroke all went away. And hypoglycemia and hyperglycemia, in my experience, are the two metabolic processes that can look like a stroke, can look like a mass lesion. Okay. Oh. O is oxygen. Don't forget to check if they're hypoxic, and if they need it, give them oxygen. N is Narcan. right? And if you think at all this patient has any sign or symptoms of narcotic overdose, they're deep, maybe they have pinpoint pupils, they may not always have it. They have a mixed OD or they're very hypoxic or hypercarbic. But if they're down and you don't know why, they're not breathing well, give them naloxone. Can I tell my rabbi story, even though I'm running late? Jimmy, can I tell my rabbi story? I gotta tell, this is my favorite story, true story. So Gernsheimer is doing his residency, second year resident at Lincoln. We rotate up to Jacoby for neuro. And I was in trouble because I wouldn't go to those conferences. We didn't even have CAT scans, and they had brain scans conference. And they had a ward full of people who were septic, throwing pulmonary emboli, stinking decubiti that were making them septic. So I would be on the ward, you know, giving antibiotics, giving heparin, that kind of stuff. And I would skip those conferences if I had sick patients. And I get yelled at, so I was in trouble. The biggest reason I was in trouble was the chief resident in neuro, and this is true, Dr. Schwartz. Her husband was my co-intern and resident at Lincoln. And when I was an intern, working every third night, no night float, we went on a double date with her and her husband and her best friend from childhood. And I fell asleep on the date. And I never called her best friend again. So I was in real trouble of flunking. One day near the end of the rotation, I get called down to the ER, and there's a Hasidic rabbi, payas, beard, right? And they say he has a pontine stroke. So I look at him, he's hardly not breathing well, he has pinpoint pupils, which you can get with a pontine stroke, right? So I said, did anybody give this guy Narcan? They looked at me like I was anti-Semitic. Remember, this was Einstein, Jacoby, right? So I said, well, I'm the only one who even can speak Yiddish here. How could I be anti-Semitic? So I went to, so after they made fun of me, I said in Yiddish to myself, Genuch is genuch, enough is enough. And I went and I got the naloxone myself. And I gave 2 milligrams, which is the dose you want to give if someone's hardly breathing, right? Especially if they're not an addict. And he woke up, right? Turned out, I didn't do him a big favor. What had happened was he had terminal CA, and it accidentally was in so much pain, overdosed on his Percocet. And he died a couple weeks later in agony from pain. So I didn't do him any favors. But after that, they couldn't fail me, right? So I passed. It was great. Whatever. And thiazide. You have someone who's really cachectic, especially if they have weird eye findings. They may have an acute Wernicke's. Give them thiamine 100 milligrams. But don't, if they're hypoglycemic, don't worry about giving the thiamine first. Give them the glucose, right? No matter what the book says. Remember that Coma never read Tintinelli, never read the book. Okay. And always monitor them closely. All right, so what about the history? Important, get it when you can. Remember, you can't rely on the patient to give you a history. So you call. This is when you call. This is when you check old records, right? This is when you tell EMS, not just on the oral boards, but in real life, to wait so you can get the history. Okay. Good physical. Always check the vital signs. They're vital. And they may give you a clue to the overdose, to the delirium. For example, someone is hypertensive, tachycardic, change in mental status, dilated pupils, but good bowel sounds, very diaphoretic. Young person, what do they probably have? South Bronx, cocaine overdose. Come on, guys. All right. Signs of trauma, always. Look for them. And a good neuro exam looking for focality especially, right? And here's a good neuro exam. Rich, you do that all the time, that good neuro exam, right? Sure. Okay. Herniation. Someone has a mass lesion, right? Bleeding in their head. Change in consciousness is one of the most early signs, and you may get it even before you get focal findings. So just remember that. Okay? You want to look at the vital signs. They'll start to have abnormal breathing. Right? They may have hyperventilation. They may then have chain stoking. They may like oh well. Is that good, Rich? Chain stokes. They may then get very irregular breathing, amniotic or viral breathing, and they're about to stop breathing. You better intubate them. Right? They may blow their pupils. They may have weakness on one side. And then they herniate, and if from a mass lesion, they lose their oculovestibular reflex, it's too late. They're a vegetable. Right? Only exception is if it's something like a narcotic or especially a barbiturate overdose. But it's too late. Okay, lab evaluation, routine bloods, but also think, just don't order everything, but think of special bloods. Oh yeah, woman comes in coma, other people in the house are complaining of severe headache, the parakeet and the cat died, right? What special blood might you send? CO2. Yeah, carbon monoxide level. So think, right? Very important. Use your clinical judgment. Monitor them, pulse ox, EKG, right? Maybe they're in AFib and they threw a big embolus somewhere, right? That would be a clue. So, very important. Put in a Foley if they're in coma. Get a urine, maybe a UTOX. Chest x-ray. C-spine, maybe if they have significant trauma above the clavicle, a C-spine, or maybe better yet, a CT of the spine. CT scan, when are you going to do that? Well, if you have any focality and hasn't responded to sugar, they're not hypoglycemic, then I would do it early. On the other hand, there's no evidence of focality by the history. Doesn't sound like the confusion is from trauma or a bleed. And so, looking for other causes first before I would do a CAT scan. If you find no other cause and they're getting deeper, then I would get the CAT scan. And obviously, anytime they develop an acute neuro finding, you get that CAT scan. Okay, what about lumbar puncture? You suspect meningitis, or you suspect that they have a subarachnoid, but the C-scan, CT was negative, then you do the lumbar puncture. And everybody talks about, well, you need a CT scan first. There was a nice study from Cook County from a long time ago, where they looked at who probably needs an LP after the CT. And those were obviously people with head trauma, people who had focal findings, older people, people like with HIV. But if you had no focality, you were kind of young, you didn't have an underlying immunosuppressive disease or a history of a brain tumor or something like that, no evidence of a mass lesion, then you could do, if you suspected this was meningitis, you could do the LP without a CT in this study. Okay. And EEG, I just threw that in because if Dr. Z was here, I'd say one of the differentials is status epilepticus, even though they're not having shaking, they could still be if they're not waking up. And an EEG might help you. Or a really good clinician. So yesterday at UHB, we had a guy in coma, me and Christiana, right? And she picked it up, not me. Right? I was busy talking as usual. But she picked it up that this person who wasn't any more shaking, she noticed the eyes were deviated and there was a little fluttering of the eyelid. I said, Dr. Gernsheimer, let's give him Ativan because I think he's still in status. He had had some seizures previously. Sure enough, he was in status. That was better than that. What is this? On the CT, you don't want to miss? Come on, guys, help out an old Jewish man. Subdural. All right, so my differential diagnosis. So the mnemonic I like are vowels giving you tips, right? A-I-O-U tips, right? Here they are. I'm not going to read them for you. A, E, that I can read. I, O, give me an O. I can do that one. Uremia. T's, these are big ones, right? Insulin, I like the insulin. Too much, you go into hyperglycemic coma, like my dog. Too little, you're hypoglycemic, right? Here are the other ones, and these. Okay, and these. And an important one here is psychiatric. So rule out diagnosis, or the patient's faking, or the patient is psychotic. That's a rule out, right? First you use your clinical judgment to look for things that are more important. Okay, management. So ABC's always, stone therapy, treat specific causes, like herniation. How are you going to treat that? You're going to ventilate the patient well, get the airway, ventilate them. We no longer hyperventilate them, but we don't hypoventilate them. Okay, that'll help. Then, if there's no C-spine trauma, you can put their head up at 30 degrees. Okay? Then, you can either give them mannitol, 1 gram per kilo, up to 100, with a Foley in. You don't want to bust their bladder. Or you can give them hypertonic saline. Old guys like me like mannitol. Up in Kings County, the neuro critical guy, he likes the saline. And if it's not traumatic, but if it's like from a brain tumor, then you can give dexamethasone. But steroids do not help with herniation from brain trauma. Okay? Other things, always support. Someone who's delirious, psychological, social support has been shown to help. Hydration, nutrition, pain. Pain in elderly people can set off delirium. If you want to treat that. Restraint, and sedation is needed. And what do I like to sedate with? Haldol for most things, I like. The exception being for withdrawal syndromes, for someone who's had a seizure with the delirium, toxic stuff, like wild cocaine, I like to use a benzo, Ativan or Valium, okay? If in an older person, you're going to sedate them because they're delirious, start low dose Haldol, 1 to 2 IM, you can repeat it as necessary. Start low, go slow, right? That's the mantra for giving drugs in old people, right? And don't snow them under too quickly, even though people will be yelling at you, oh, Granny is jumping out of the bed and we don't have someone to watch them and that kind of stuff. You do the right thing. And I don't give Haldol IV. The reason I don't is, yeah, you'll get away with it, but if you don't get away with it and they develop prolonged QT and torsades, it is not approved for IV use, and then you might get in trouble. So I only give it IM. Okay. Disposition, appropriate consultations. Most are going to be admitted, except for mild intoxication and except for mild hypoglycemia. Okay? Okay. So I was stumped about this case, so I needed someone smarter than me. So I went to my daughter. Okay? I said, Dawn, what should I do? And How should I evaluate further? What are my main diagnoses? How am I going to manage this woman at UHB? Right? All right, so I got a rectal temp. Because you can't trust an oral temp in a person who's very confused and can't keep that thing under their tongue with the mouth closed. You just can't. And I had a case yesterday with Noah where orally the temp was like 99.8. And then we did a rectal temp because this guy with a change in mental status sent from first psych and then J, arrived from the J Suite, the HIV clinic. And we did the rectal temp. What was it, Noah? 101.6, and the guy was septic. So be very careful with oral temps. Finger stick was 30. Okay? EKG showed many VPCs, even short runs of VTAC. Right? Glucose 32, high white count with a shift. Urine stunk and was full of white cells after we put the Foley in. Okay? Hyponatremic, hypokalemic. And what do you think about that BUN and creatinine? What do you think what kind of renal failure this is? And impress me because you have Rich who's boarded in nephrology. So what kind of renal failure is this? Pre-renal, right? Creatinine to BUN ratio greater than 20, although that's not that sensitive or specific. It's this case, we know she's dehydrated. Okay, and DIG 5.5. What is that? That's high. Normal levels like between 1 to 2, right? 0.8 to about 2.2. Very high. Probably why she has all these VPCs. Her EKG also show Salvador Dali's mustache, right? Kind of wavy T waves, ST depressions. All right, so she had urosepsis. She had adverse drug reactions to DIG. The Lasix was also messing her up. She also, the diabetic meds making her hypoglycemic. So she was hypoglycemic, dehydrated with electrolyte stuff, dysrhythmias, hyponatremic, and hypokalemic, and really septic, right? True case from UHB. So what did we do? Sugar, sugar, sugar. She got a lot of D50. She got a lot of fluids. She got potassium. She got antibiotics, Zosyn. She got Digibine for the Dig overdose. We stopped all the meds. We monitored her. We admitted to the ICU. I had to, plead with Dr. Fahmy, promised him my daughter. And that's it. So time for questions. Any questions? Okay. So in summary, I'm following the Dr. Willis's thing. In summary, after my questions, ABCs and don't therapy, get an ample history, a good PE, a good neuro exam, right? Ample history, allergies, medications, past medical history, last meal, last menses, and the event, good HPI. Treat specific causes. As you find them, look for them and treat them. Neurosurgeon consult after getting a stat CC and seeing something operable. Monitor them very closely and be nice to them. Right? My references, the main one is actually the chapter in Tintinelli is really excellent for this with a lot of good references. That's all you really need for this. Really nice chapter. And that's it.